Hi, this is Giuseppe Argenziano from Naples, Italy, and I would like to share with you today a few thoughts about the topic of re-excising lesions for which the histopathologic diagnosis is not clear-cut. Okay, let me give an example. This is a 62, 63-year-old man, and as you can see from his back, is fair skin, heavily sun-damaged skin, and there is particularly this lesion which is already clinically a little bit worrisome and dermoscopically clear-cut. This is a suspicious lesion because of the irregular distribution of colors and structures. So we decided to remove this lesion, and this was clear-cut melanoma, so no problems. Okay, so then of course the patient underwent monitoring follow-up because he had a melanoma. And 1 year later, we were catched by the lesion, which is just immediately below the scar. And as you can see, after 1 year, the lesion is changing already on total body photography. This is what we can see on close-up, and dermoscopically you see again a kind of irregular lesion, asymmetric with irregular network and a little bit of gray color in the center. So this is a lesion I don't like. I would like to remove this lesion, and we removed it. And by the way, the histopathologic diagnosis came out as a compound nevus with severe dysplasia. What is a compound nevus with severe dysplasia? Is it really something in between a normal nevus and a melanoma biologically? No, I don't think so. This is an intermediate lesion morphologically. Okay, so this lesion is definitely either benign or malignant, but morphologically is a little bit in between, not only for us clinicians, but also for the pathologist. That's why he's using the term nevus with severe dysplasia. So now the question is, should we re-excise this lesion, yes or no? Well, it depends. It depends from what we as clinicians think about the lesion. Are we more on the side of a melanoma from a clinical point of view, or we are more on the side of a nevus? If we are more on the side of a melanoma, we should re-excise this lesion. And let me give you an example why I think so. Okay, this is a middle-aged woman, and she is coming to us with a new lesion appearing on the extremity of a scar. Okay, and she brought us the pathology of the lesion excised 2 years before on the forearm, and this lesion 2 years before, the excised lesion was categorized as a junctional nevus with severe dysplasia again. Okay, and at that time the clinician decided not to re-excise the lesion. And now we have a recurrence, a local recurrence, and look how ugly is this lesion. And definitely this is not a nevus with severe dysplasia. This is a melanoma of 0.9 millimeter in thickness. So now the question is, was this lesion 2 years before a dysplastic nevus, and now there is a recurrence of a melanoma, or this was a melanoma from the beginning? In my view, the logical thinking is bringing to me to the conclusion that this was already a melanoma 2 years before, and now there is a recurrence. Why? Because the lesion was not re-excised. So should we re-excise the lesion that I showed you before on the 64-year-old man? I think so. Yeah, because my understanding from a clinical point of view is that this lesion, it could be melanoma, so it's better to re-excise. So the final decision on what to do, what management we should use in the context of lesions which are a little bit difficult to diagnose for the pathologist, depends on us, depends on the clinical context, on the eventual monitoring we did for the lesion, the morphology of the lesion, and we should decide independently what to do. And with this, I thank you for your attention. Bye bye.